Good evening, everyone. I am Dr. Sri Krishna. I'll be substituting for Dr. Jyotsna. She's not well, so I'll be taking over. Thank you for giving me this opportunity. So I'm going to talk about flower MI trial and will it alter the way we do primary PCI? So when we see multiple lesions in a STEMI patient, so we need to ask ourselves few questions like what is the culprit lesion and does it require PCI? Most of the times it is clear which lesion is the culprit lesion. So sometimes we may have to use multiple modalities. So it is fairly straightforward. Then what about the non-culprit lesions and how to address them? And so the questions about the non-culprit PCI that we have to ask are, should they be stented, in whom to stent, when to stent exactly, and is physiological assessment needed? So should they be stented? I think the previous speakers have clarified it. Yes, they need to be stented. They will result in better outcomes. So this is a trial published by, paper published by Atty et al. In 2020. It is actually a meta-analysis of all the major trials involving the culprit vessel versus non-culprit PCI from 2004. So it included 10 RCTs. It included the Denami Premalty trial, even up to the complete trial. So around 7,000 patients were total were analyzed in this in this meta-analysis. So a strategy of multi-vessel PCA was associated with 31% lower risk of reinfarction, 29% lower risk of cardiovascular mortality, and 66% lower risk of repeat revascularization. And but all-cause mortality was not decreased, and there was no difference in major adverse cardiovascular events. So when to address the non-culprit vessel? It is either in the index as a part of the index procedure, or according to the complete trial, within 45 days, the outcomes doesn't vary whether they're done with in the same hospitalization or after readmission. So then the last question that needs to be answered is whether a physiologically guided strategy to stent the non-culprit vessel is useful. So the flower MI trial is for this purpose. It is to define the usefulness of FFR guided revascularization for non-culprit vessels. It is a study done in France in 41 centers. So this is the study design. Once STEMI patient successful primary PCA was done to the culprit vessel, they were randomized in 1:1 fashion. These patients had an angiographically significant lesion of more than 50% stenosis in another vessel. So they were randomized before doing a physiological assessment in a 1:1 ratio. Half of the patients were randomized for angio-guided PCI during index hospital and the other half were randomized to FFR guided PCI. The follow-up was done at 1, 6, 12 and 36 months. The primary endpoint is a composite of all-cause mortality, non-fatal MI, unplanned hospitalization with urgent revascularization at 1 year. The analysis was done at the end of 1 year. So this is the inclusion criteria. So all the patients aged 18 years and with non-culprit lesion of more than 50% angiographic stenosis were included in the study. The exclusion criteria were the usual exclusion criteria for all these non-culprits vessel studies, like cardiogenic shock, previous bypass surgery, CTOs, or life expectancy less than 2 years in patients where FFR could not be performed. So around 1,200 patients were randomized, 581 patients to the angio-guided PCA group and 590 patients to the FFR-guided PCA group. So this is the procedural data. Here we can see that staged FFR was done in 95% of patients of the FFR group, and I want to highlight these 2 points that are highlighted in red. Out of 95% of patients who underwent FFR, 66% of patients ended up having stents. And in the angiography group, 97% of the patients ended up having stents. The mean number of stents that are used in the FFR group is 1, and in the angio-guided group, it is 1.5. So the primary outcome at the end of 1 year is similar in both the groups. You can see that the hazard ratio is 1.32. The p is not significant. The confidence interval is very wide, 0.78 to 2.23, and the actual endpoint, the primary endpoint, is in the flower MI trial is 4.2% with the angiography guided group and in 5.5% in the FFR guided group. There's no statistical significance. Compared to the previous trials where FFR was used, the primary endpoint was much less in the flower MI trial. They initially expected for enough power for the study, they initially expected a endpoint of at least primary endpoint of at least 10%, but they ended up with less than 5%. The complete trial had a primary endpoint of 8.9%, Compare Acute had 7.8%, and Dynamic trial has an endpoint of 13%. So this is the comparison of the primary endpoints. There is no difference between MACE, death from any cause, myocardial infarction, or unplanned hospitalizations. And even the secondary endpoints like the stent thrombosis, revascularization, hospitalization for heart failure, or hospitalization for ischemia, there is no difference between the two groups. And the number of anti-anginal medications that the patients were put on post-PCI and the quality of life was also similar between the two groups. And the patients who returned with angina was also similar between the two groups. So, coming to the summary of this trial, PCA was performed in 66% of patients in the FFR guided group, whereas it was performed in 97% of patients in the angiography guided group. So FFR utilization has led to deferral of PCA in 1/3 of patients. But when lesions in which there is a 70%, at least 70% stenosis of angiographically was in these subset of lesions, when FFR was done, the revascularization rate is 85%. So the FFR in more than 70% stenosis lesions had decreased the revascularization rate by only 15%. So the mean number of stents as expected in the FFR group it was 1, and in the angiography group is 1.5. This is a study in France. So they found out that the median cost of FFR guided PCI exceeded angiographic guided PCI. They found that the angiographic PCI guided PCI was more cost effective. So conclusions from the flower MI trial. In patients with STEMI and multivessel disease, the event rate of MACE at 1 year is low. Whether it is a angiography guided strategy or an FFR guided strategy, the event rate is less, only around 5% in the flower MI trial. For a non-culprit lesion revascularization, definitely stage procedure is preferred. Then FFR guided PCI of the non-infarct vessel and angiographic PCI does not have any difference in primary endpoints. So the limitations of this trial were the study is underpowered because they got a primary endpoint which is much less than the expected, and there is wide confidence intervals, and the peri-procedural MI was underreported in this group. And also because it is a study in STEMI patients, peri-procedural MI was hard to be identified. So another caveat that we have to see here is, can FFR be performed in STEMI patients, patients presenting with ACS? We know that there is significant microvascular dysfunction in patients presenting with ACS. So there is a blunted vasodilatory ability. So the distal PD is increased. FFR is PD by PA. So because PD is high, we get a false FFR values, falsely high FFR values. So our strategy is to perform FFR on the, let's say within 5 days of the index event, but the FFR, it takes few weeks to return to normal. So FFR may not be an ideal strategy to perform in ACS patients. And this is a paper I found, this was published in 2020. This is a study from CMC Vellore, where they sought to find out the cost effectiveness of FFR guided strategy in stable ischemic coronary patients. They found that, so here there are for 477 coronary lesions, they for whom interventions was planned, an FFR was done, and then based on FFR the intervention was done. They found out the overall incidence of MACE was 4.9% in the angiography guided group and 6.9% in the FFR guided group. But the average cost saving in Indian population, they found that after this was published in 2020. So after ceiling of stent prices, they still found out that FFR guided strategy decreased the each patient expenditure by at least 18,000. So impact of clinical practice on clinical practice after this flower MI trial, especially for Indian population, is still FFR guided versus angiographic guided PC of non-culprit vessel is unclear. However, definitely a multi-vessel revascularization should be done, because if the FFR is done to lesions more than 70% stenosis angiographically, 85% would of the patients would be getting stents. So if the patient has a stenosis of more than 70% angiographically, it is probably better to stent. So one way FFR, we have to consider another fact that PCI is not a benign procedure. It has its own complications, especially more so in ACS patients when we are doing a primary PCI. So FFR may prove useful in reducing the number of stent implanted, thereby reducing the risk of peri-procedural MI. And when we decrease the number of stents implanted to the patient, we are also decreasing the risk of very late stent thrombosis. This may be especially useful in patients who have very long longevity from the time of stenting. So it's better to avoid over-stenting them. And in Indian
Doctor.
Yes, all done.
Yeah, can you?
So further, the further question to ponder upon is plaque identification stabilization in this setting in the setting of ACS is more important than seeing whether the lesion is significant or not. This is the Prospect trial published in 2011. They followed up 300 patients for 3 years. They found that more than 50% of MACE events were because of non-culprit lesions, and more than 50% of these lesions had angiographic stenosis of less than 30%. So a vulnerable plaque identification and stabilization should be the next strategy to treat these patients. Thank you.